Dear friends, welcome to the show Talk with Your Doc. I am Dr. Prashant Tijani, and with us is today Dr. Gabriel Mapeso. Dr. Mapeso is a general surgeon at Thunder Bay Regional Health Science Center in Thunder Bay, Ontario. And today he is going to guide us about how to prepare for the surgery. In our lifetime, either ourselves, one of our family members or friends do undergo one or other type of surgery. And it is very important to know how do we prepare for the surgery, because preparation for the surgery means the safe surgery and the fantastic outcomes. So Dr. Mapeso is going to guide us about how to prepare for the surgery. Thank you, Dr. Mapeso, for coming to the show Talk with Your Doc.
Thank you very much for the invitation, and I really like this kind of topics because a lot of people don't understand what they're undergoing through. So we can probably start. Can I start?
Yeah, please.
We can probably start with a few things like very simple stuff. The understanding that you mentioned that the goal is for a safe operation so that people minimize the risk of complications, and hopefully the surgery will everything go smoothly without any major problems and get out of the hospital and recover well. So there's a few things that you have to understand why we want certain things, and one of them is stop smoking. Because the reason being is that most people, when they are not asleep, they have a limited respiratory function or reserve. Once you put them to sleep, they will lose that reserve and they cannot wake up. So you will lose something.
So smoking, you said we should stop the smoking. So how many days before or how many weeks before we stop the smoking?
Oh, ideally is a few weeks at least, and you can do some exercise to increase your tolerance, but at least a few weeks. Hope the longer the better, obviously.
So when we stop smoking, it improves our lung function so that we can tolerate the surgery better?
Yes, because most surgery, if you are put under general anesthetic, that's where it becomes very, very important, is when you are asleep.
So the smoking hampers our lung function. So it's very important to stop smoking before surgery and even after surgery, probably.
Yes, correct. So that's just one aspect of it.
Right. Now, there are various types of surgery like inpatient surgery, outpatient surgery. So what is the difference between these different type of surgeries?
So inpatient surgery, day surgery we call it, inpatient or in hospital or same day admit. So there are different criteria. Some patients needs to be extensively prepared and have to be admitted before the surgery in order to make them or optimize them and make it safe for the surgery to occur. In some people, the surgery is safe enough to be done, we call it a same day.
Same day surgery.
So they come in and there's a same day admit, and then sometimes there's also a same day discharge. If the surgery involves not many dysfunction of your system or your GI tract or your lungs, then you can be done and then discharged. So it all depends on the type of surgery you have, the location of the surgery, the extent of the surgery, and the seriousness of your condition too.
Correct.
So if you have a very serious health condition, then you might have to be monitored longer and you may have to stay in.
Okay. Now, so same day surgery means patient gets admitted in the morning and get discharged by the evening?
Yes.
And then inpatient is he has to come one day before and stays longer for a time after the surgery is done?
Correct. Most of the patients now are same day admit, and we're trying to streamline the healthcare, the process, and some people are already prepared many days or a few weeks before, and they just come in on the day of their surgery if everything is can be safely done that way.
So one thing you mentioned is stop smoking.
Yeah.
Is there anything else one should be taking care of before he gets admitted for the surgery?
Yes, there's a few other things. One of the things that they don't understand is the medications too. The medications there are certain medications that definitely has to be stopped. One of them is the medications that alter bleeding. So if it increases the bleeding tendencies, then absolutely they have to be stopped. If they are heart medications, some of the heart medication cannot be stopped.
Mm-hmm.
They have to continue it because or else they will have problems during the surgery. So, and the other thing that patients don't understand is that we also give blood thinners so that they will not have any blood clot.
During the surgery.
So it's very paradoxical that we have to say stop blood thinners, but we actually give blood thinners. The difference is the blood thinners you're taking is therapeutic. The blood thinners we give is prophylactic, so it's a lower dose to prevent blood clots.
Correct.
Yeah.
Now, does patient have to have a special diet before they get admitted for the surgery?
In general, not. So the diet is very important if you have bowel surgery. And it depends on the location of the surgery. If you have a general anesthetic, the safest for everybody is to have an empty stomach.
No food before how long?
No food. The standard is we have accepted for many years is about 6 hours before the surgery. However, recent studies have shown that as early as 4 hours is safe enough. However, the convention right now is we'll just accept the 6 hours. The reason being is that when you are having surgery, some people get nauseated or they feel sick with the many drugs that we give. So if they throw up, if the stomach is empty, they don't choke, they don't have any problems. But if there's food in the stomach and you eat, then you might have the risk of aspiration. Choking, aspiration, pneumonia. So in fact, if you eat before your surgery less than 6 hours, it's automatically cancelled, guaranteed.
Okay. So it's very important to have fasting, no food at all.
Yes.
Any liquid is allowed before the surgery?
Liquids with sips, especially if you can take the medication. A sip of liquid or water, clear water, or a sip of clear juice is allowed to take your medication so you can swallow.
Nothing.
No tea, no coffee.
Okay.
Yeah.
So it's very important to control the diet 6 hours before the surgery.
Correct.
Right. Now, how about the diabetes, the sugar control?
The sugar control has to be stable or under control. If it is out of control, so to speak, then usually your surgery is delayed simply because if your diabetes is out of control, you will have higher risk of complication. Having said that though, we do emergency surgery, so we have to deal with what we have. But in elective surgery, you have to be optimized, so your diabetes has to be under control. Your diabetes medication can be modified, they can be given half the dose because you will not have anything to eat, so you won't need as much of the insulin or diabetes medication. So it has to be modified and you have to tell, or else your blood sugar will go down too. We have to monitor it more frequently.
How about the alcohol?
Alcohol is, we try to avoid alcohol because alcohol affects the liver and it can give you liver test abnormalities. It can give you stress, ulcer, gastritis, inflammation in the stomach. It also interferes with certain drugs, so it's very important. And in fact, in some of the medication can definitely either affect severely the level of the drug, so that it's really not advisable to have any alcohol on board. No alcohol on board.
Are the patients given laxatives or enema before the surgery?
Especially with bowel surgery, this is where the crucial thing about enemas and bowel preparation is important. The reason being is that even if you do not have bowel surgery, your bowels generally go lazy with the many drugs that we give, the narcotics that we give. So if you haven't had a poop and you're bound up, you will probably get more constipated after a general anesthetic or surgery. So we generally make sure that you have at least a laxative or you have had a good bowel movement in order to avoid constipation. The other thing, obviously, if you have bowel surgery, we generally sometimes give you a bowel clean out.
Okay. Thank you, Dr. Mapeso. We'll take a short break and we'll continue after the break.
Thank you very much.
Thank you. Please stay back for the next part. Welcome back to the show Talk with Your Doc. With us is today Dr. Gabriel Mapeso, who is a general surgeon at Thunder Bay Regional Health Science Center in Thunder Bay, Ontario, and he is guiding us about preparations for the surgery. Dr. Mapeso, you were mentioning about bowel preparation for the surgery. Once the patient is prepared with all the things which we mentioned earlier, what are the other things he needs to take care of before he joins the surgery? So how about the consent for the surgery?
The consent has been modified several times, and in this day and age, the consent is very important. It is part of preparation of the patient in order to understand that what the operation is, and for the patient understand what he or she is undergoing. So in the consent form, it is important that the operation has been discussed thoroughly with the surgeon and that he has answered all the questions that the patient has about the surgery, and that the patient also understands the surgery. And if he is not able to consent, then somebody else has to consent for it. The other part of our consent form is also the blood products. So there are certain persons that would not like to have blood products, and they have to indicate so that we can get the proper consent.
So without consent, surgery cannot be started.
Definitely, without the consent, surgery cannot. You cannot go through the operating room. You cannot even you cannot even get prepared if you don't have consent.
So what is the age limit cutoff for the consent? Like children, can they give the consent, or the parents have to give the consent?
Well, in general, if the patient is in the pediatric age group, below the age of consent, the parents has to give consent. And if they're over 16 years old, generally they can give consent themselves.
Okay.
But it's probably better even for you to have your relatives know what you're undergoing through. Even if you know how to give consent, it's wise to make sure that your relatives know what you're undergoing.
Right. Now, when the patient comes to the hospital and they have given the consent and have prepared everything, so then they are given the ID wristband on their body part. So what does this ID band contain?
The ID is another way of ensuring safety for the patient, and that is what we call a safety checklist. And in the safety checklist, because there's so many things going on in the operating room, in fact, our operating room, we have 14, 15 operating rooms. So a lot of people are going through during the day. We have to make sure that the right patient goes to the right room, the right patient goes to the right surgeon, and the right patient goes for the right surgery. And because the patients sometimes are sedated, or sometimes with all the stress that they're undergoing, they just assume that they're going to be taken through. So there is a risk for some problems if the patient is not identified carefully. So the patient has a wristband, and when they're anesthetized, we know who the patient is. And when they're recovered, they're still recovering, they're very sleepy, we know who the patients are. So it is very important that patient is properly identified, indicated who they are. And some patients get frustrated because they're asked several times, who are you? What is your name? Please do not get upset with it. It's not that we don't know what we're doing, but we just have to ensure we have the right patient for the right surgery.
Right, right. So once they have an ID wristband and they remove all their cosmetics, right? Or jewelry or makeup or everything?
Yes, they do, because the makeup, especially in the fingernails, the makeup might interfere with some monitoring devices and conduction of electricity. So especially the fingernails, one of our oxygen monitor is reliant on the fingernails and in the fingers. So if there is color or there's nail polish, it will interfere with detection of the pulse oximeter, we call it, for the oxygenation. And that is very important, because you can't survive without oxygen for a few minutes.
Yes.
So your oxygen is always monitored every second. So you have to have a clean nail and no nail polish. That's one. The jewelry conducts electricity, and it has been known in the past that sometimes we use electrocautery and it can conduct electricity to your jewelry, and you can have skin burns or serious burns as well. So it is important that you do not put any jewelry or take it off as well.
Right. And do the patient have to disclose what drugs they are allergic to, what drugs they are taking at this time?
Correct. And that's one other thing that they are asked, is their allergy. And a lot of people are very good at that, because they are aware if they're allergic to something, it can be a serious problem. So obviously, when the patient's undergoing anesthetic, we can't ask any questions anymore. So we have to know that information preoperatively, and we have to indicate in the wristband, in the chart, what they are allergic to, and we do not give that drugs.
So when the patient enters into operation theater, who are the people around him or her? What are the staff around there?
Okay, this is, a lot of people probably don't understand this. So hopefully, people will realize that when you go into the operating room, there are a lot of people.
Yes.
So it's what we call a teamwork. So the OR operates on the premise that everybody works as a team. And I do my part as a surgery. The anesthesiologist, who's another physician, will put you to sleep. And then there's a scrub nurse, we call it, and the scrub nurse can have an assistant. And then there's a circulating nurse. The circulating nurse is the one that can get other instrument or equipment that's around. And then we have the learners. And I will also have, for major cases, surgeons generally have assistants. So at least a minimum in major surgery, you will have at least 5, 6, or 7 people in the operating room. And when we are scrub and operating, we are sterile, considered sterile, and we cannot touch anything else outside our operating field. So if we need anything, we rely on the other circulating nurse to get something. And we may get some x-rays, special x-rays and stuff like that. So it's a unit that has to be prepared many days, many weeks before in order for that to get together.
Now you mentioned about anesthetist, and they make you to sleep. There are 2 types of anesthesia, probably general and local anesthesia.
Yes.
So can you please explain us about different types of anesthesias?
The anesthetic is, as you mentioned, the local anesthetic. It's only a regional, so it's only localized to that area where the surgery is. And if you are in the operating room, in general, we can still do that, but we usually do local anesthetic in ambulatory care because it's a much better, efficient way of doing it. But if you do have a general anesthetic, you do have some sedation, sedative too. You are entirely asleep, and people don't understand that you are actually paralyzed to some degree, and you cannot breathe on your own. So they put a tube down your throat when you're asleep. The moment you're asleep, they put a tube down your throat, and you are hooked up to a respirator or a machine that breathes for you. Okay. And then we can do our operation. So the other thing is what they call a spinal anesthetic. So any operation below the umbilicus or below the belly button, around the hips, knees, and the foot, you don't, especially for people who cannot tolerate an anesthetic, they just freeze. We call it freezing you from the waist down. So it's a spinal anesthetic, and they just put a needle in the back spine and then put a drug and then anesthetize the nerves, and usually it's completely numb and you can't feel anything.
So local anesthesia, patient is awake and knows what the things are going around?
Yes, unless they are sedated, because sometimes if the patient is anxious, we can give you sedation. A little bit of sedation and anxiolytics as well, if we give some local anesthetic. Yeah.
So once the patient is undergoing the surgery, even before the surgery or after the surgery, there are certain preparations or treatments given to prevent the deep vein thrombosis or plugging of the veins?
Yes.
So can you explain us a little bit about that?
When a lot of people do not understand too that we give you actually blood thinners, one of the risks for being put to sleep and not moving is you develop blood clots in the legs, especially with bowel surgery, orthopedic surgery, leg surgery. So we give you a blood thinner actually, but a low dose. We call it a prophylactic dose. And with that, usually it's continued after the operation, depends if you are mobile or immobile, or depends on your activity. So we titrate that one to make sure that you are okay, your blood test is okay, that you are not going to be a bleeder. And so we give you that, anticoagulants, we call it.
Thank you, Dr. Mapeso. We'll take a short break and we'll continue.
Thank you very much.
Please don't go away. We are remaining with the last part of the show. Welcome back to the show, Talk with Your Doc, and Dr. Mapeso is guiding us about how to prepare for the surgery. Dr. Mapeso, you were mentioning about blood thinners to prevent the deep vein thrombosis in the legs. Is there any other treatments or alternatives to prevent the thrombosis?
Yes, there is, because we occasionally encounter patients who cannot take blood thinners, or it is contraindicated to take blood thinners. So instead of giving them blood thinners, we put stockings on the legs. That's one option. Or the other option is to put, we call a sequential pump device, and it's a stocking with several bladders, air bladders, that pump sequentially the leg. You might call it massaging the leg. It actually massages your leg. It has a sequential pumping sequence. It pumps the lower, the mid, and the upper, and lower, mid, and upper. So it's continuously making the blood flow in the leg instead of being stagnant. And the one thing I didn't mention is that if you have a blood clot, it's very serious. You can have a lung clot, which can be very serious, and some people actually die from it. So we don't want you to have that one. So we try to prevent blood clots in the legs.
Right. What are the investigations done before the surgery starts? Does patient has to undergo any laboratory workup?
Yes, there is, and a lot of people also don't understand that we just can't do surgery right off the bat, especially electively. So one way to prepare you safely is very basic blood tests like what is your hemoglobin, what is your iron level, sort of, what is your white count if you have any infection in the body or not. We do urine tests to see, make sure there's no silent urinary tract infection, which can be problematic. And then we do electrolytes, we call it, the minerals in your body. They're very basic. And then if you're over 50, in general, we do an EKG to make sure your heart is functioning right and there's no irregularity, and we do a chest x-ray as well. So those are some of the basic things. And one of the other things is we generally do a test to see if you're not clotting abnormally. So we do a what we call an INR and PTT to make sure you're not a bleeder and you're not going to have any trouble with bleeding.
That's good. Are the patients given antibiotics before the surgery?
Yes, the antibiotics is also important. The antibiotics, you might have heard that antibiotics can be harmful if you just give it indiscriminately. So we try to only give it in cases that is needed, and we only give the minimum dose as needed, the minimum but the appropriate amount of dose, and that is prophylactically if it's a dirty contaminated operation, or there's a high risk for infection, or it's what we call a clean contaminated, especially bowel surgery. We do give prophylactic antibiotics. Yep.
Okay. Now, once the patient is in the operation theater, there are various monitors which are monitoring the patient, and they put the IV line, the needles in the hand. Can you please explain us about the IV? What is IV?
Okay. When you are asleep, one of the way to safely monitor you, because you're totally asleep and paralyzed and you're on the ventilator and you have no knowledge of your body, and your body homeostasis is almost like dependent on what we're doing to you. So we have IV to give drugs immediately if there's any problems. You're given intravenous fluid because you can't drink or eat, so you don't get dehydrated. And then we put a Foley catheter sometimes, most of the time if the operation is longer, so we can monitor your urine and your kidney function. And then we have pulse oximeter as well, and then plus the intubation tube, and then plus the oxygen monitor, then the blood pressure cuff. And then besides the intravenous, which is the IV, we also put an arterial line to monitor your blood pressure. And that's like second by second monitoring of your blood pressure basically, and the way your heart is pumping out blood, and we can literally do a blood test immediately from that too. So it's actually on your radial artery, it's an artery, an intra-arterial instead of intravenous. So that is constantly monitored. Well, let's say I'm doing the operation, the anesthesiologist is monitoring, and his assistant or the nurses are constantly monitoring. And if you actually watch TV, there's always a monitor beeping, and that's the heart rate. There's sounds associated with low or high oxygen, and so we can safely monitor how the patient is going.
Okay, that's good. Now, once the patient is done with the surgery, he or she goes to the recovery room.
Yeah.
So what is the recovery room?
So after going through the operation, you have to have your anesthetic reversed, or what we call recover you from the surgery. So you go to the recovery room, and you are sort of, if you actually look at the recovery room, if anybody has been there, you will see that it almost looks like a mini ICU. You are completely monitored with almost like an ICU. Your heart, your lungs, your oxygenation, your blood pressure, blood test is needed. And we are very lucky here in Canada because we have the capability to do that, and we have the funds to do that as well compared to other countries. And you are monitored until the anesthetic has been completely reversed enough, and also you are more awake and you are stable enough to be transferred to the floor or even to the day surgery, which eventually you will be discharged.
So that's about 24 to 48 hours or more?
And recovery from the anesthetic in recovery room usually in general is about an hour.
Okay.
It's about an hour
And then
for you to recover. Then you can be moved to the day surgery or back to the floor.
Back to the floor.
Yes.
So once you are back to the floor and you are discharged back to home,
Yeah.
what are the precautions to be taken?
Well, I'm just going to point out that from recovery room, you go to day surgery to the floor. You are still continuously monitored more frequently to make sure that there's no other problems, and then you will be discharged. So in the discharge planning, which is obviously planned as well for the safety of the patient, is wound care, pain control, follow-up, removal of sutures, dressing changes, pain, whether you have more or less pain medication, follow up with your family doctor, follow up with your surgeon, any anticipated problems that you have to notify the physician, or you may have to go to the emergency room if there are certain serious problems. So all of that is sort of run down or mentioned to the patient to prepare him to make sure that he's discharged safely.
Right. So patient has to take care of their sutures so that they have to limit their activities to a certain extent, right?
Yes, in general we do. However, though, if there's no contraindication to being active, we generally encourage them to be moved around. Now, we don't want them jumping around or running around, but at least they should be mobile because it decreases, minimizes the risk of blood clots in the legs. And a lot of people have the misconception that if you just had surgery, you should be lying around and trying to lie down in bed, which is actually quite serious. You can actually have more serious consequences. The best thing is almost like an athlete, once they recover, they have to push themselves, push through the pain in order for them to get back into full function.
That's wonderful. Thank you, Dr. Mapeso. You gave us a lot of good advice for the surgery.
Oh, you're kindly welcome. Thank you very much for your invitation.
Thank you, everyone.